stimulus is absent. In contrast to the normal cell, here the growth factor and stimulus is absent. Even without that, mitosis, that is, it lost physiological control. So even in cessation of the stimulus, in absence of the stimulus, in absence of the growth factor, it keeps on dividing. So mitosis is uncontrolled. In neoplastic cells, the mitosis is not under control. Mitosis becomes uncontrolled. Uncontrolled mitosis leads to neoplasia. Here the mitosis is controlled. What do you mean by controlled in normal cell? So whenever growth factor is coming, then only it is dividing, otherwise it's not dividing, it's controlled. Here even in absence or presence, it doesn't matter, it keeps on dividing. So from one cell, 2 are formed, you can see. From 2, 4 are formed. From 4, 8 are formed. From 8 to 16, 16 to 32, 32 to 64, 64 to 128. Likewise, it keeps on growing, 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 and a mass of cell is formed, and that is neoplasia. That is neoplasia. You want to see? See. So this is one cell dividing into 2, 2 dividing into 4, 4 dividing into 8. It keeps on dividing, 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 and a mass of cell which is formed is known as neoplasia. I hope you got the difference between a normal cell and a neoplastic cell. Normal cell, the cell division is under control. So it divides only when the stimulus is present, and it divides and stops. It do not keep on dividing, dividing, dividing. From 1 to 2 are formed. Now if you want from 2 to 4, another growth factor or stimulus has to come. It will not keep on dividing. But in contrast to that, this is neoplastic cell. It keep on dividing, dividing, dividing. It do not require any stimulus. That is uncontrolled mitosis. So what is the definition of neoplastic cell? What is neoplasia? What is neoplasm? Neoplasm is the abnormal mass of tissue. Abnormal mass of tissue which is formed. Here the mitosis, the growth is accelerated, uncoordinated. The mitosis is uncoordinated, and it occurs even after cessation of the stimulus. The stimulus is absent. Even after that, the mitosis, the growth keeps on going. So basically, neoplastic cell is such a cell which has lost the control and regulation of replication. I hope you don't learn the definition and you understand it and you write it in your own language in university exam. So please write in your own language. Don't try to mug it up. So this is the definition of neoplastic cell. Now coming on the nomenclature. There are two types of neoplasia. There are two types of tumors. Benign tumors and malignant tumors. What are benign tumors? What are malignant tumors? What is the nomenclature of them? Let's come on benign tumor. All the benign tumor ends in the suffix oma. So suffix is oma. For example, papilloma. What do you mean by papi? Papi means finger-like projections. Can you see? The tumor is arranged in finger-like projection and it's a benign tumor. So that's why I say papilloma. Papi means finger. Oma means benign tumor. Second is adenoma. What do you mean by adenoma? Ade means glands. So oma is a benign tumor. So it's a benign tumor of the glands. Can you see? These all are glands. These all are glands. So it's a benign tumor of the glands. It is known as adenoma. So papilloma, adenoma. See the suffix is oma. Let's see the suffix here. These are the benign tumors. These are the malignant tumors. Currently, I am interested in the benign one. So it is squamous cell papilloma, liver cell adenoma. You can see lipoma, fibroma, myxoma, chondroma, osteoma, synovioma, leiomyoma, rhabdomyoma, hemangioma, lymphangioma, meningioma, lymphoma, and fibroma. You can see the suffix is oma. In all of them, the suffix is oma. Oma means benign tumor of that particular thing. Benign tumor of adipose tissue, lipoma. Benign tumor of fibrous tissue, fibroma. Likewise. So it is oma. It's always oma. So learn the benign tumor ends in oma. Learn the two special names. What are the two special names I told you? Papilloma and adenoma. You can get MCQs on that. Okay. But there are 4 exceptions. You have to learn the 4 exceptions. These are the 4 tumors which have suffix as oma. See, the suffix is oma, but they are not benign. They are malignant. So although they have the suffix as oma, but they are malignant. They are 4 in number. You have to learn. So melanoma. It's the malignant tumor of the skin. Although the suffix is oma, but it's malignant. Seminoma. It's the malignant tumor of the testes. Mesothelioma. It is the malignant tumor of the pleura of the lung. And lymphoma is the malignant tumor of the lymph nodes. Suffix is oma, but it's malignant. Seminoma. It's the malignant suffix as oma, but they are malignant. They are 4 in number. You have to learn. So melanoma. It's the malignant tumor of the skin. Although the suffix is oma, but it's malignant. Seminoma. It's the malignant tumor of the testes. Mesothelioma. It is the malignant tumor of the pleura of the lung. And lymphoma is the malignant tumor of the lymph nodes. So these 4 are malignant tumors or neoplasm, but they have the suffix as oma. Now coming on the nomenclature of malignant tumors. We have seen the nomenclature of benign tumors. The nomenclature of malignant tumor depends in which cell that malignant tumor is occurring. In human body, there are 2 types of cells, mesenchymal cell and epithelial cell. If the malignant tumor is occurring in mesenchymal cell, it is known as sarcoma. The suffix is sarcoma. I will show you the example. And if it is arising in the epithelial cell, it is known as carcinoma. It is known as carcinoma. It can be adenocarcinoma, squamous cell carcinoma, but the suffix is carcinoma. So see, these all are epithelial origin. Now don't see the benign one, see the malignant version. They are epithelial. They are epithelial origin. So you can say squamous cell carcinoma, transitional cell carcinoma, adenocarcinoma, hepatocellular carcinoma, choriocarcinoma, melanocarcinoma. So see the suffix as carcinoma when it is epithelial origin. Now let me show you the mesenchymal origin. If it is mesenchymal origin, it is liposarcoma, fibrosarcoma, myxosarcoma, chondrosarcoma, osteosarcoma, synoviosarcoma, leiomyosarcoma, likewise. You can see. Now the benign version is oma, lipoma, liposarcoma, fibroma, fibrosarcoma, myxoma, myxosarcoma. Likewise, read the list completely. So learn the benign of all, learn the malignant of all. Now in adipose tissue, the person can have benign tumor, the person can have malignant tumor. If the person is having benign tumor of the adipose tissue, the person, we will say the lipoma. And if the person is having malignant tumor of the adipose tissue, we will say liposarcoma, lipoma, liposarcoma, fibroma, fibrosarcoma. Likewise, read the list completely. So what we have learned, what is the summary? We have learned that tumors are of two types, benign and malignant. Tell me the nomenclature. So benign tumors end in suffix oma. Whether epithelial or mesenchymal doesn't matter. But learn the four exceptions. All of them end in oma except four. Four of them are malignant, but they have the suffixes oma. Which four? You have to learn the four exceptions. And I guess everyone knows the four exceptions. Melanoma, seminoma, lymphoma, mesothelioma. So that is the four exceptions. Now coming on the malignant tumors. Malignant tumors depend. Malignant tumor can be of epithelial origin or can be of mesenchymal origin. If it is epithelial origin, the suffix is carcinoma. And if it is mesenchymal origin, the suffix is sarcoma. So we have three suffixes. One of them will be present. So suffix oma means benign. Suffix carcinoma and sarcoma means malignant. But here the origin will be different. So we have seen all. Now coming on the precancerous condition of predisposed benign. Suffix carcinoma and sarcoma means malignant. But here the origin will be different. So we have seen all. Now coming on the precancerous condition or predisposing conditions for the cancer. So cancer predisposing conditions, we divide them into two categories. Genetic predisposition and non-genetic predisposition. There are three conditions in genetic predisposition. Let's start with genetic predisposition. Autosomal dominant cancer syndrome, defective DNA repair syndromes and familial cancer. They all have genetic predisposition. So there is a list of cancers. All of them are autosomal dominant. They have a genetic inheritance. Okay, so I'm having a mnemonic to learn this list. The mnemonic is very rich, cute, nice man. Very rich, cute, nice man. Hereditary, like familial females. Very rich, cute, nice man. Hereditary, like familial females. So B stands for von Hippel syndrome. R stands for retinoblastoma. T stands for Cowden syndrome. N stands for neurofibromatosis 1 as well as 2. M for toothaches, melanoma and MAN1 2. Hereditary, H stands for HNPCC. Hereditary non-polyposis colonic carcinoma. L for Lysoni. F for familial adenomatous polyposis. And one more F, familial breast tumor. So please learn the mnemonic: very rich, cute, nice man. Hereditary like familial female. Very rich, cute, nice man. I will write it again. Very rich, cute, nice man. Hereditary like familial females. So this is the mnemonic. If you can write the mnemonic, saying full form is very easy. So learn the list. They all are autosomal dominant hereditary cancer syndrome. So they run in the families. There is heredity in them. So there is a gene which is mutated and that is go to the generation by generation. So it is autosomal dominant inherited cancer syndrome. If the parents are having, the siblings will also have that. The offspring will also have that. So that is the thing. Now the second is the defective DNA repair syndrome. So whenever DNA damage is there, we do the DNA repair. DNA repair genes are present. But sometimes there is a defect in the DNA repair system and is autosomal recessive. So there are total 5 diseases associated with that. Now exactly which step of the DNA repair is defective? Based on that we classify them. Is the nucleotide accretion repair is defective? So the disease is xeroderma pigmentosa. If the mismatch repair is defective, it is known as non-hereditary polyposis colorectal carcinoma. And if the recombination repair is defective, it is Bloom syndrome, ataxia telangiectasia and Fanconi's anemia. So if you don't want to learn the classification, learn all 5 together. And to learn all 5 together, I am having a mnemonic. The mnemonic is big facts. B stands for Bloom, F-A-X, F is Fanconi, A is ataxia telangiectasia, X is xeroderma H is HNPCC. And all of them are autosomal recessive except HNPCC, which is autosomal dominant. So that is defective DNA repair. Learn the 5 diseases here. So what we have learned, very rich, cute, nice man, hereditary like family of female. This is the autosomal dominant inherited cancer syndrome, and these 5 are defective DNA repair. And finally, there are certain familial cancers which have high frequency to run in the families like breast cancer, ovarian cancer. They do not have any distinct pattern, but they run in the family. So out of the genetic, if we have seen the cancers which have high frequency to run in the families like breast cancer, ovarian cancer, they do not have any distinct pattern, but they run in the family. So out of the genetic, we have seen there are 3 genetic predisposition. What are the 3 genetic predisposition we have seen? So I am telling you the precancerous condition. I told you in precancerous condition we divide them into 2 groups: hereditary or genetic, one is the same thing, and non-hereditary. So first we have completed the hereditary. In hereditary we divide them into 3 categories: autosomal dominant syndromes we have seen, DNA repair defective syndrome we have seen, defective DNA repair system, and finally the third one we see there are certain familial cancers. So you have to learn the mnemonic. In autosomal dominant the mnemonic is very rich, cute, nice man, hereditarily like familial genes. And here in defective DNA repair, the mnemonic is big facts hair. That is the mnemonic. And here we don't have any mnemonic. Breast and ovary cancer is the example. So basically you have to learn the example. Coming on non-hereditary or genetic. So in non-hereditary or genetic we have 2 things: the proliferation and chronic inflammation. Whenever there are certain proliferative conditions, whenever there is proliferation, so proliferation means the genetic mutations get accumulated one by one and it can lead to cancer. For example, regeneration, metaplasia, hyperplasia, dysplasia. Here in proliferation there is increased accumulation of the genetic mutation. Hello everyone, accumulated one by one and it can lead to proliferation and chronic inflammation. You have any mnemonic. Breast and ovary cancer is the example. So basically you have to learn the example. Coming on non-hereditary or genetic. So in non-hereditary or genetic we have 2 things: the proliferation and chronic inflammation. Whenever there are certain proliferative conditions, whenever there is proliferation, so proliferation means the genetic mutations get accumulated one by one and it can lead to cancer. For example, regeneration, metaplasia, hyperplasia, dysplasia. Here in proliferation there is increased accumulation of the genetic mutations. In chronic inflammation, cancer. For example, regeneration, metaplasia, proliferative conditions. Whenever there is proliferation, so proliferation means the genetic mutations get accumulated one by one and it can lead to cancer. For example, regeneration, metaplasia, hyperplasia, dysplasia. Here in proliferation there is increased accumulation of the genetic mutations. In chronic inflammation, whenever there is a chronic inflammation of any particular organ, inside that organ cytokines are there that causes increased cell survival and that can lead to cancer. And there is also genetic instability due to chronic inflammation and that can also lead to cancer. So we are done with cancer predisposing condition. Now you will get a short test: is increased accumulation of the genetic mutations. In chronic inflammation, whenever there is a chronic inflammation of any particular organ, inside that organ cytokines are there that causes in this session we are going to discuss so proliferation means so in non-hereditary or genetic we have 2 things: the proliferation and chronic inflammation. Whenever there is proliferation, so proliferation means the genetic mutations get accumulated one by one and it can lead to cancer. For example, regeneration, metaplasia, hyperplasia, dysplasia. Here in proliferation there is increased accumulation of the genetic mutations. In chronic inflammation, whenever there is a chronic inflammation of any particular organ, inside that organ cytokines are there that causes increased cell survival and that can lead to cancer. And there is also genetic instability due to chronic inflammation and that can also lead to cancer. So we are done with cancer predisposing condition. Now you will get a short question. Either simply on the definition of neoplasia, you can define it. Neoplasia is the new growth. The new growth is known as neoplasm and the branch is known as oncology. So basically neoplastic cell is such a cell which has lost its control over cell growth or mitosis. It is having uncontrolled mitosis. Even in absence of stimulus, it keeps on growing. So we have seen the definition. Nomenclature wise, we have seen it is of 2 types: benign and malignant. All benign have the suffix oma. There are 4 exceptions, you know that. And all malignant have the suffix either carcinoma or sarcoma. And you know the examples. Now coming on genetic predisposition. In genetic predisposition, we have precancerous condition. There are 2 genetic and non-hereditary. In the genetic, the first is autosomal dominant cancer syndrome. You know the mnemonic: very rich, cute, nice man, like, hereditarily like familial females. And for for defective DNA repair syndrome, the mnemonic is big, bad, hair. And familial cancers are ovarian. Harry, an important topic that is hereditary like familial females. And for defective DNA repair syndrome, the mnemonic is big, bad, hair. And familial cancers are ovarian. And in non-hereditary, it can be proliferation and chronic inflammation. That's all about it. So whatever is asked, write that portion only. I hope you got it. So don't forget to see all the questions, p-values, especially the short and very short questions from this topic. Hello everyone. In this session, we are going to discuss three special terminologies in neoplasia, that is teratoma, hamartoma, and coriostoma. You usually get short question or very short question on these three terminologies in your university exams. So let's start it. So here I will be discussing three things: teratoma, hamartoma, coriostoma. So first we will see everything about the teratoma, followed by we will see the hamartoma and coriostoma, which are not actual neoplasm. So let's start with teratoma. Now in human body we have multiple organs. All the organs during embryonic stage, they are derived from one of the three germ cell layers. So there are three germ cell layers are there, that is ectoderm, mesoderm and endoderm. And each organ is derived from one of the germ cell layer. So if any tumor occurs in any particular organ, that tumor is derived from one germ cell, not from all three. So either the tumor derived from ectoderm or mesoderm or endoderm, one of them. So most of the tumors, maximum tumors in human body, they derive from one germ cell, from which that particular organ is formed from the embryonic life, in embryonic life. But what are teratomas? The teratomas are the tumors which arise from totipotent cells. What are totipotent cells? The totipotent cells are the cells, these are the cells which can differentiate into any of the three germ cells. It can differentiate into ectoderm, it can differentiate into mesoderm, and they can differentiate into endoderm also. So basically, teratoma is a tumor, is a type of cell tumor. It is composed of multiple derivatives of the three germ cell. So it contains, sometimes it can contain all three germ cell. It can contain the derivatives of the ectoderm, it can contain the derivatives of mesoderm as well as derivatives of endoderm. So it is a unique tumor. It's a type of germ cell tumor in which the components is derived from multiple germ cells, maybe all three germ cells sometimes. So that is teratoma, unique tumor. So it can contain multiple components, like sometimes it can contain the teeth, hair, bones, muscle inside the tumor. It usually occurs in the gonads. In males, it can occur in the testes, and in the females, it can occur in the ovaries. Now you can see this is the gonad, the testes or the ovaries, inside which you can see the teratoma. Now the cut surface, you can see the tip is present, you can see the hairs are present, sometimes the bone is present, you can see all these components. Usually it is benign, but sometimes it can be malignant. So that is teratoma. It is a tumor which is derived from the totipotent cell. So it can differentiate into the components of any of the three germ cell layer. That is a unique thing about the teratoma. Now coming on two different terminologies, that is coriostoma and hamartoma. Both of them are not actual tumors. They are not tumors. They are not actual tumors. Now looking at the suffix oma, coriostoma, hamartoma, you may feel like they are the tumors. They are the benign tumors. No, they are not at all tumors. So these are the lesions with tumor-like names, but these are not tumors. So what is coriostoma? What is coriostoma? Coriostoma is a normal tissue at abnormal size. And what is hamartoma? Hamartoma is abnormal tissue at normal site. You'll say, what does it mean? Normal tissue at abnormal site, abnormal tissue at normal site. So it's a little bit confusing. We will see the details wait. So let's start with hamartoma. Let's start with hamartoma. What is hamartoma? In hamartoma, the site is absolutely normal. The site is absolutely native or indigenous. So site is normal, but only thing tissue become abnormal. What is abnormality in the tissue? Tissue become focally maldeveloped. This is focally malformed. I mean, it is not dysplastic, it is not anaplastic. For example, let's take the example of lung. You know, inside the lung, in the respiratory tract, the cartilages are common. Do you know that? Of course, we have dysplastic, it is not anaplastic. For example, let's take the example of lung. You know, inside the lung, in the respiratory tract, the cartilages are common. Do you know that? Of course, we have cartilage in the lung. So you can see this is the cartilage which is present in the lung only. So you will say the site is normal, the site is indigenous, the site is nature. Cartilage is usually present in the lung. It's normal. The only thing it become malformed. Here the cartilage become malformed. It is not dysplastic, it is not anaplastic, it is not cancer. The only thing it become malformed. So it is the hamartoma of the lung. In the same way, do you know inside the spleen we have two pulp, red pulp and white pulp. Both the pulps are normally present in the spleen. So here inside the spleen you can see red pulp is there. So of course it's normal site. Site is indigenous, site is native, site is normal. The only thing the red pulp become malformed. The red pulp of the spleen become malformed. So basically the tissue is formed, but its site it is normal only. Whatever it should be, it is that only. So that is hamartoma. Now coming on the next terminology, that is choristoma. What is choristoma? What is choristoma? Choristoma here, the site is abnormal, but the tissue is absolutely normal. Now have a look on the tongue. Can you see this is tongue? On the tongue, what is this? Oh my god, what is this on the tongue? On the tongue, we can see osteocartilage. Osteocartilage is present. Let me show you. You can see this is the osteocartilage is present on the tongue. So on the tongue, we don't have osteo. Now if you cut it, it's absolutely normal. It's not malformed, it's not dysplastic, it's not anaplastic. So tissue is absolutely normal, but the only thing, its site become abnormal. Normally on the tongue, we don't have any osteocartilaginous component. But here the site is abnormal, the site is ectopic actually. So that is known as choriostoma. Similarly, you can see we are doing the endoscopy here of the stomach. We are doing the endoscopy. And inside that stomach, we found something and we cut it and we see it's absolutely normal pancreas. Absolutely normal. Not malformed, not disformed, no dysplasia, no aneuploidia, nothing. But inside stomach we don't have pancreas normally, right? So here the tissue is absolutely normal. The only thing is side become abnormal. Inside the stomach there is pancreas. So that is choriostoma. So I hope you got it. What does it mean? So what is hamartoma and what is choriostoma? What is hamartoma? What is choriostoma? In hamartoma, what is normal and what is abnormal? Learn abnormal. What is abnormal? What is normal? What is abnormal? In choriostoma also learn what is normal and what is abnormal. So basically don't try to learn both. If you try to learn both, you will get confused. So how to learn? In hamartoma, the tissue is abnormal. Basically it is malformed, but it is present at the normal site, the indigenous site, the native site. But in choriostoma, the site is abnormal. It's ectopic, but tissue is absolutely normal here. The tissue is absolutely normal, not malformed. So learn what is abnormal. So how to learn what is abnormal? So in hamartoma, the tissue is abnormal. So obviously site is normal. And in choriostoma, the site is abnormal. It's ectopic. Obviously tissue is abnormal. Tissue is normal. So learn what is the abnormality. Obviously the other thing is normal only. This is how I learn. Okay. So I never get confused. Hamartoma, abnormal tissue. Choriostoma, abnormal site. Learn the summary. So we have seen the three special terminologies on. Usually you will get the short questions in your exam. Teratoma is a unique tumor which is derived from totipotent cell. So it can differentiate into ectoderm, mesoderm, endoderm. So it can contain various components inside the tumor. So inside the testes or the ovaries, whenever teratoma is there, the person can have tips inside the tumor. Yes, teeth, hair, muscle, brain inside the tumor. So technically anything can be present inside this tumor. Usually it's benign, but sometimes it can be malignant. What is hamartoma and choriostoma? In hamartoma, the tissue is abnormal, so site is normal. In choriostoma, the site is abnormal, but the tissue is normal. And you can understand them, both of them with examples. I hope you got it. So don't forget to have a look on long question, short question, very short question, and MCQs from this topic which are given in the notes section and question bank. everyone. In this session, we are going to discuss the ultra important topic, that is benign versus malignant tumors. So you have to differentiate the benign tumors and the malignant tumors based on 5 important properties. Usually, you can get a long question on that. So you have to differentiate the benign versus malignant tumors with 5 properties, with proper diagrams and everything. And sometimes you can get a short question on any of the one property or feature of anaplasia. So let's start it. So you can see here we are starting the topic, that is benign versus malignant tumors. So let's start benign versus malignant tumors. So we have to differentiate the benign tumors from the malignant tumors based on the 5 features. First of all, we will differentiate them based on their rate of growth. Then we will differentiate them based on their clinical features. Then we will differentiate them based on their gross and microscopic features one by one. In the microscopic feature, we will see the anaplasia, the 10 features of anaplasia. So anaplasia is a hallmark of malignancy. All the anaplasia features are absent in benign tumors and they are present in malignant tumors. So we have to see what is anaplasia and what are the 10 features of anaplasia and how it is used to differentiate the benign tumors from malignant tumors. And finally, the last one, the most important one, which is used to differentiate the benign versus malignant tumors, is spread of the tumor. So one by one, we will differentiate the benign tumors from malignant tumors based on these 5 features. They are in front of you. So let's start it. So first of all, we are starting with the first feature, that is rate of growth. Based on rate of growth, how we differentiate the benign tumor from the malignant tumor. Benign tumor are slow growing and the malignant tumor are very fast growing. That is the meaning of the rate of growth. So whenever any patient is coming complaining of a lesion or a mass anywhere in any part of the body, the first thing is its rate of growth. I mean, is it a slow growing mass or it's a fast growing mass? So that will give a guess or an idea, is it benign or is it malignant? Exceptions are always there, but it will give you a rough idea, rough guess that is it benign or is it malignant. Benign tumors are slow growing. They have less mitotic rate. That's why they are very slow growing. And the malignant tumors are very fast growing because they have high mitotic rate. They have high mitotic rate, that's why they are very fast growing. Now, please understand a concept here, that is doubling time. What do you mean by doubling time? For example, here is the mass, there is a tumor that is 1 centimeter in diameter. Now, from 1 centimeter, what is the time required for this tumor to become 2 centimeter? And what is the time required by this tumor to become the 4 centimeter? So, what is the time required by the tumor to become double in size? That is known as doubling time. Now, I told you benign tumors are very slow growing. So here doubling time is very high because they are very slow growing now. So they require years and years sometimes to get doubled, maybe many months or years. But I told you the malignant tumors are very fast growing. So here doubling time is very less. Very quickly, within few days or few weeks, they just double. They keep on doubling. So benign tumors, the doubling time is more because they are slow growing. They require more time to get doubled. And malignant tumors, they are very quick, they are very fast growing, they have high mitotic rate. So within few days, they become doubled. So here doubling time is less. So you have to understand the benign tumors versus malignant tumors based on rate of growth. That is the first feature. Now the second feature is the clinical features. Based on the clinical features, how we can differentiate the benign tumors from malignant tumors? Benign tumors are slow growing and usually asymptomatic. I am saying about usually. Exceptions are there. And malignant tumors are rapidly growing and usually they are symptomatic. For example, they can ulcerate, they can invade, they can show the metastasis, but exceptions are there. Now, malignant tumors are rapidly growing and usually they are symptomatic. For example, they can ulcerate, they can invade, they can show the metastasis, but exceptions are there. Now let me tell you one exception. I told you most of the benign tumors, they are asymptomatic. Now consider meningioma. You can see meningioma is the benign tumor of the meninges of the central nervous system. So, but sometimes it can produce seizure. It can be horrible in presentation. So, it is not always that all benign tumors are asymptomatic. Sometimes they may produce the symptoms, the serious symptoms. And in the similar way, I told you malignant tumors are usually symptomatic. They can ulcerate, they can invade. But for example, consider breast cancer. Breast cancer at initial stage, it's absolutely asymptomatic. No pain, nothing. So, sometimes it is, exception is there. Usually the benign tumors are asymptomatic, but exceptions are there. And usually the malignant tumors are symptomatic, but exceptions are there. That is the summary. Now coming on the third feature is the gross. Based on the gross, how we differentiate the benign tumors from the malignant tumors based on the gross. So how we can differentiate? Benign tumors are spherical, capsulated. Malignant tumors are irregular and no capsule is there. Can you see here? Now both of them, you can see the two images here. Both of them are tumors of the breast. This is the benign tumor of the breast, that is fibroadenoma, and you can see this is the malignant tumor of the breast, that is invasive ductal carcinoma of the breast. Now you can see here the tumor is, let me show you the boundaries here. You can see here the tumor is spherical, oval or spherical in shape, and you can see here the tumor is irregular in shape. Now appreciate. Here the benign tumor is well encapsulated. This one is well encapsulated. You can appreciate here, and this one is non-encapsulated. This one is freely mobile. This one is well encapsulated. This one is well encapsulated. You can appreciate here, and this one is non-encapsulated. This one is freely mobile. This one becomes fixed. So you can appreciate grossly. Looking at the gross, you can get. So you can see again the same diagram. This is the benign tumor. You can appreciate. And this is the malignant tumor. The benign tumor are spherical, oval, well encapsulated. The malignant tumors are irregular in shape. They don't have any capsule and they are fixed. So you can see this is spherical, this is irregular. This is encapsulated, no capsule is there. Now the benign tumor compress the surrounding tissue and malignant tumor invade the surrounding tissue. What do you mean by that? What do you mean by that? Compression means pushing. The benign tumor is pushing the adjacent tissue and producing symptoms. It is pushing the adjacent tissue and producing the symptoms. But malignant tumor don't push, it invade. It invade inside the tissue. It don't push, it just penetrate. Invasion means penetration. It will penetrate inside the tissue and produce the symptom. So benign tumor push, that is compress the surrounding tissue. But malignant tumor penetrate, that is invade the surrounding tissue. So that is the cross. After that, coming on the fourth feature, that is microscopy. So let's revise the first three. So what we are doing, we are differentiating the benign tumor from the malignant tumor. We have to differentiate based on 5 features, 5 properties. So out of them, 3 are done. The first is based on their growth rate. So that is the gross. After that, coming on the fourth feature, that is microscopy. So let's revise the first 3. So what we are doing, we are differentiating the benign tumor from the malignant tumor. Benign tumor push, that is compress the surrounding tissue. But malignant tumor penetrate, that is invade the surrounding tissue. So that is the gross. After that, coming on the fourth feature, that is microscopy. So let's revise the first 3. So what we are doing, we are differentiating the benign tumor from the malignant tumor. We have to differentiate based on 5 features, 5 properties. So out of them, 3 are done. The first is based on their growth rate. The first feature is based on their growth rate, we have to differentiate them. Second, based on their clinical features, we have to differentiate them. And third, based on their gross, we have to differentiate them. Followed by microscopy and spread, I will tell you. So based on the growth rate, the benign tumors are slow growing. The malignant tumors are rapid growing or fast growing. Here the mitotic rate is very high. Here mitotic rate is very low. Since your mitotic rate is very high, the doubling time is less. It requires high time to get doubled. And here, since I just said the reverse. Here you can see benign tumors have low mitosis, very low mitosis. They are slow growing now. That's why doubling time is very high. It requires years to get doubled. Okay. And here in malignant tumors, the mitosis is very high. They go on dividing. They keep on dividing. That's why here the doubling time is less. Here the doubling time is very less. So based on the growth rate, this is how we can differentiate them. Now coming on the clinical features, benign tumors are usually asymptomatic, but exceptions are there. And malignant tumors are usually symptomatic, but again exceptions are there. Now coming on the gross findings, in the gross you can see benign tumors are spherical in shape or oval in shape. The malignant tumors are irregular in shape. Okay, the benign tumors are well encapsulated. Here capsule is present, and these are poorly encapsulated. Here capsule is not. Okay, benign tumor compress the surrounding tissue, and malignant tumor invade, that is penetrate in the surrounding tissue. So please learn the differences by heart. Now coming on the fourth feature, based on the microscopy, the most important one. Based on the microscopy, how to differentiate them. Now, there is a term you have to understand here. The name of the term is anaplasia. Anaplasia is a hallmark of malignancy. Anaplasia is present in malignant tumors, not in benign tumors. You will say, what is anaplasia? I don't know what is anaplasia. Please explain. So anaplasia is lack of differentiation. You may be thinking, ma'am, what is differentiation? First understand what is differentiation, then see the lack of differentiation is anaplasia. And please understand anaplasia is absent in benign tumors prescription, the hallmark of malignancy. Anaplasia is present in malignant tumors, not in benign tumors. You will say, what is anaplasia? I don't know what is anaplasia. Please explain. So anaplasia is lack of differentiation. You may be thinking, ma'am, what is differentiation? First understand what is differentiation, then see the lack of differentiation is anaplasia. And please understand anaplasia is absent in benign tumors, present in malignant tumors. Anaplasia is the hallmark of malignancy. So please understand what is differentiation. Here you can see there is a tissue. Can you see? Yes, this is a tissue. In this tissue, you can see this is the tumor cell. Can you see? And the remaining one are the normal cells. Now see the tumor cells. Tumor cells, these all Due cells. You can see these all are tumor cells. And you can see these all are normal cells of that tissue. Whatever tissue it is, it can be any tissue from head to toe in human body. Now the tumor can occur in any of the tissue. You can see these are the normal cells. These are the normal cells. And you can see these are the tumor cells or the cancer cell in that particular tissue. Now you have to say that cancer cell or tumor cell, how much resemblance of the cancer cell or tumor cell is there as that of normal cell. That percentage of resemblance is known as differentiation. So tumor cell, up to what extent the tumor cell is morphologically or functionally, it is looking like the normal cell, or is it completely different? So you have to tell me the extent of resemblance between the cancer cell and the normal cell, the percentage of resemblance. So that is known as differentiation. And lack of differentiation is known as anaplasia. What is anaplasia? Lack of differentiation. So basically the tumor cell are completely different from that of surrounding tissue, from that of the normal cell. There is no resemblance at all. That is known as anaplasia. So anaplasia occurs in malignancy. It's the hallmark print from that of surrounding tissue, from that of the normal cell. There is no resemblance at all. That is known as anaplasia. So anaplasia occurs in malignancy. It's the hallmark of malignancy and it's always irreversible. You see now how I will come to know that whether a particular tumor is having anaplasia or don't have any anaplasia. For example, a patient is coming to my clinic. The complaint of the patient, she's a female patient and she is feeling a mass in her breast since last few days. So this is the breast and inside the one of the breast, she is feeling a mass. She is feeling a nodularity, she is feeling a mass in her breast. Now it can be a benign tumor, it can be a malignant tumor in a section of the hand. So thanks. Anaplasia is malignancy. It's the hallmark of malignancy and it's always irreversible. Listen, how I will come to know that whether a particular tumor is having anaplasia or don't have any anaplasia. For example, a patient is coming to my clinic. The complaint of the patient, she's a female patient and she is feeling a mass in her breast since last few days. So this is the breast and inside the one of the breast, she is feeling a mass. She is feeling a nodularity, she is feeling a mass in her breast. Now it can be a benign tumor, it can be a malignant tumor, I don't know. So what to do? Do biopsy. The first thing you have to do the biopsy. On the biopsy, look in the microscope the features of anaplasia. If the features of anaplasia are absent, it's a benign tumor. If the features of anaplasia are present, it's a malignant tumor. And whatever the tumor is, based on that, decide the further course. If it's a benign tumor, you can just do the surgery, that's it. If it's a malignant tumor, after surgery, you have to give chemo also and radio also. And you have to give targeted therapy, hormonal, decide the further course. If it's a benign tumor, you can just do the surgery, that's it. If it's a malignant tumor, after surgery, you have to give chemo also and radio also. And you have to give targeted therapy, hormonal. Therapy. So that will be the different courses. So benign tumors versus malignant tumor. You may be thinking, ma'am, why it is necessary to differentiate benign tumor versus malignant tumor? Is it necessary? Both of them present as a mass at any part of the body. Why it is necessary? Being a doctor, why it is necessary to differentiate benign from malignant? because treatment of both of them is different. This requires only surgery, that's the mask, at any part of the body. Why it is necessary? Being a doctor, why it is necessary to differentiate benign from malignant? Because treatment of both of them is different. This requires only surgery, that's it. This after surgery or before surgery, it requires chemo also and radio also, sometimes targeted therapy, sometimes hormonal therapy, various therapy. And what about the second thing, prognosis? Here prognosis is good, having no recurrence. It never recurs. Here the prognosis may be poor sometimes depending on what stage we are doing the diagnosis and their recurrences are common. So that is how, that is what. No recurrence. It never recurs. Here the prognosis may be poor sometimes depending on what stage we are doing the diagnosis and their recurrences are common. So that is how, that is why we have to differentiate whether the tumor is benign or malignant. It is not the thing the patient is coming with a mass, you have to operate it, that's it. No, no, no. First do a biopsy, become sure whether the tumor is benign or malignant. Based on that, tell the further treatment to the patient, consult the patient and tell the prognosis to the patient based on that. So if any lady is coming to me having a breast nodularity, the first thing I will do is the biopsy. Based on the biopsy, I will decide whether tumor is benign or malignant, and I will tell the proper treatment and the prognosis to that patient. So in the biopsy, what I will look for? I will look for features of anaplasia, whether anaplasia is present or absent. You will see, ma'am, how to see anaplasia? Anaplasia is seen microscopically. So for anaplasia, you require a slide. It has to be seen microscopically. Okay, it is not seen grossly. In the microscopy, you will see anaplasia is present or absent. So if any mass is present, take the biopsy and make a slide. And on slide, look for these 10 features. If all the 10 features are absent, it's a benign. And if all the 10 features are present, it's malignant. So anaplasia is the hallmark of malignancy. Got my point? These are the 10 features that define anaplasia. These are the 10 features that define anaplasia. They all are absent in benign tumor and they all are present in malignant tumor. So in short, I will explain all one by one. So in short, we can say anaplasia is absent in benign and anaplasia is a hallmark of malignancy. Okay, now what are the 10 features? One by one, we will look at them. So we will look all the 10 features, you can count all the 10 features in these two diagrams. You can see here the diagram is showing normal and here the diagram is showing anaplasia. We will differentiate them based on this diagram. The first feature is loss of polarity. Let's start it. What is loss of polarity? What do you mean by loss of polarity? Now you can see this is a normal tissue, see the cells, and this is the anaplastic tissue, see the cells. Can you see the cell? Let me mark this is the cell, this is the cell. Okay, let me draw it on another page. Now here I am drawing the normal. Here I am trying to draw the normal and here I am drawing the anaplasia. Okay, in the normal these are the cells. I am trying to draw the cells, the epithelial cells here. And here I am trying to draw the anaplastic cells. Here I am trying to draw the anaplastic cells. Okay, like this. Okay, now see, this is basement membrane. We have a basement membrane here and we have a basement membrane here. Where is the nucleus? Nucleus is never in the center normally. Normally the nucleus is towards the basement membrane. You can see it's not in the center, it's towards. It's towards the basement membrane. This is normal. Can you see? This is normal. So normally basal polarity is present. It is known as basal polarity. So normally basal polarity. What do you mean by basal polarity? So nucleus is towards the basement membrane. The pole, there is a north pole, south pole, that is the polarity. So the polarity of the nucleus is towards basal membrane. So basal polarity is present here. Normally it's present. But in anaplasia, the nucleus is big in size and it is away from the basement membrane. The basal polarity. So nucleus is towards the basement membrane. The pole, there is the north pole, south pole, that is the polarity. So the polarity of the nucleus is towards basal membrane. So basal polarity is present here. Normally it's present. But in anaplasia, the nucleus is big in size and it is away from the basement membrane. It is not towards the basement membrane. It's away from the basement membrane. Can you see here? Now see the difference. This is anaplasia. So can I say here the basal polarity is absent? Absolutely. Here the basal polarity is absent. So you can see and you can differentiate this is normal or benign. And this is anaplasia or malignant. So in anaplasia, the basal polarity is lost. So first thing, if I am having a slide, I will look whether the basal polarity tumor. If the basal polarity is maintained, I will say it's a benign tumor. And if the basal polarity is lost, I will say it's a malignant tumor. This is how we differentiate based on the basal polarity. You got my point? The location of the nucleus inside the cell. The same you can appreciate here. Now see the nucleus here? It's towards the basement membrane. See the nucleus here? It's towards the basement membrane. See the nucleus here? It's towards the basement membrane. On the contrary, see the nucleus in the anaplasia. You can see the nucleus. Here the nucleus is away from the basement membrane. Nucleus is away. So you can better appreciate the diagram which I have drawn. So here basal polarity is retained and here basal polarity is lost. So the first feature is basal polarity expressed in your own words. Don't write a mother. So what is basal polarity? Normally the nucleus is present along the basement membrane. But whenever the tumor cell lose the basal polarity, that is nucleus meant to lie away from the basement membrane. So in anaplasia the basal polarity is lost. The next feature here is the pleomorphism. The second feature is the pleomorphism. Here you can see all the cells are same shape, same size. Here some cells are small, some are normal, some are large. So variation in size of the cell. So normally pleomorphism is absent and here pleomorphism is present. Here in anaplasia pleomorphism is present. Pleomorphism is variation in size. Here you can see, here I can't see variation in size. They all are same size, uniform. So here pleomorphism is absent. But here I can see some cells are small, some are normal, some are large. So variation in size is there. That is pleomorphism. The presence of pleomorphism is a feature of anaplasia. So in anaplasia, till now we have seen two properties. The basal polarity is lost and pleomorphism is present. So basal polarity is lost and pleomorphism is present. So that is the second thing we have seen. We have seen basal polarity is lost here and pleomorphism is present. Pleomorphism is variation in shape and size of the tumor cell. So variation, some tumor cells are small, some are big, some are large, some are normal. So here pleomorphism is present. The third feature, I have to teach you 10 features. The third feature is the ANSI ratio. What is ANSI ratio? Nucleus cytoplasmic ratio. What do you mean by that? I will draw. Rather, I will draw. So let me draw a cell which is normal and let me draw a cell which is anaplastic. Anaplastic cell is little bit larger than the normal maybe, but sometimes it can be same size. And here this is the nucleus. Now see the nucleus normally, and here this is the nucleus. See the nucleus and the anaplastic cell. Let me draw and highlight the nucleus and the anaplastic cell. You can see this one is normal, and you can see this is anaplasia. Okay, now consider ANSI ratio here, nucleus upon cytoplasm. Consider ANSI ratio here, nucleus upon cytoplasm. The size of the nucleus upon size of cytoplasm. So see, what's the size of the nucleus here? Nucleus is small, but cytoplasm is big in size. And here the reverse is happening. Here, the nucleus is big relatively as compared to normal, and cytoplasm is relatively same or little bit larger. So here the numerator is more as compared to denominator. So you know here ANSI ratio is low. Here ANSI ratio is normal or less, and here ANSI ratio is low. You can appreciate the numerator. You can see the nucleus here, that is the numerator, and you can see the nucleus here. Compare the nucleus. So you will get the ANSI ratio. Here ANSI ratio is normal, here ANSI ratio is high. So high ANSI ratio is a feature of anaplasia. It is a feature of anaplasia. So in anaplasia, the ANSI ratio is more because the nucleus is enlarged proportionally to that of cell. So in normal cell, ANSI ratio is 1:2, but in anaplastic cell, it's 1:2. It's 1:1. Okay. Now the next thing is the anisonucleosis. What is anisonucleosis? We can complicate it. Whenever in pathology, everything is complicated. Now split the term. The basic part of split the term, you will get the name. So isonucleosis. Anisonucleosis. What do you mean by that? Anisonucleosis is a complicated term. And means no. Iso means is equal to. Nucleosis means nucleus size. The size of nucleus. The nucleus size. No equal size of nucleus. So here, see. Now see the normal diagram. Here you can see all the cells are, all the nucleus are same. Uniform. Uniform. So here all the nucleus are same or uniform normally. But here you can see some nucleus are small, some are large, some are normal. So variation in size of the nucleus is a feature of anaplasia. So here an isonucleosis is absent and here an isonucleosis is present. That is variation in size. No equal size of the nucleus is a feature of anaplasia. So that is anisonucleosis. Nucleus show variation in shape and size in anaplasia. So till now I taught you 4 features. What are the 4 features? What are the 4 features? You tell me basal polarity. Basal polarity. After basal polarity I taught you pleomorphism. After pleomorphism we have seen ANSI ratio. And after that, we have seen anisonucleosis. You tell me benign and malignant. So what is the difference between how we differentiate benign tumor from malignant tumor based on this? How we can differentiate? Here basal polarity is retained, but in malignant tumor it is lost. Here pleomorphism is absent, here it is present. Here ANSI ratio is less, here ANSI ratio is high. Here anisonucleosis is absent, here it is present. So till now, out of the 10, we have seen 4 features of anaplasia. So that is present in malignant tumors. Okay, now coming on the 5th feature. The 5th feature is the hyperchromatism. The 5th, 6th, 7th, and 8th. These are the 4 features of the nucleus. Now see the color of the nucleus, see the nucleoli inside the nucleus, see the mitosis in the nucleus, and see the number of the nucleus. So number of nucleus, color of nucleus, mitosis in the nucleus, and nucleoli in the nucleus. So we will see these 4 features for the nucleus. So first is hyperchromatism. You know what is chroma? What do you mean by the term chroma? Chroma means color. Chroma means color. Now see the color of nucleus in both of them. You can see here the color of the nucleus is relatively normal. But here in anaplasia, the nucleus becomes compact. In chromatin becomes compact. So nucleus becomes dark, more dark in color. It is known as hyper. Hyper means more. Chroma means color, dark color, chromatism. So hyperchromatism means dark color nucleus. So hyperchromatism is nucleoli inside the nucleus. Here I can't find any nucleoli inside the nucleus. No, I can't find any nucleoli. But here inside the nucleus, we can find multiple dot. That is the nucleoli. The nucleoli are present. Prominent nucleoli are present in malignant tumors. Now see the mitosis. Normally we can't find any mitosis here. See this diagram. I can't find any mitosis. And if I find mitosis, it's difficult. But here, can you see here? I can see the spindle. Appreciate the spindles over here. Can you appreciate the spindles here? Spindle function. That's the abnormal mitosis. multiple nucleus is giant cell. So again, giant cell is a feature of anaplasia. And now finally see the cytoplasm, the color of the cytoplasm. Here all cytoplasm is pink in color. Sometimes your cytoplasm is little bit bluish in color because of the mucin. Sometimes mucin is there in the cytoplasm, and lastly aneuploidy. If you see the genetics, all the cells are diploid here normally, and here aneuploidy is common. Aneuploidy is common in malignancy. So these are the 10 features you have. Genetics, all the cells are diploid here normally, and here aneuploidy is common. Aneuploidy is common in malignancy. So these are the 10 features you have to learn. These are the features of anaplasia. Can you please enumerate, help me to differentiate benign versus malignant tumors, what you have learned till now? So let me revise you. Let me help to revise you what you have learned till now. These are given here on the screen. So I told you we have to differentiate benign tumors from malignant tumors based on parameters. This is the fourth one going on. That is anaplasia. So the first I taught you based on the growth rate. Differentiate benign from malignant. Okay, the first feature based on the growth rate. This is anaplasia. My 1, 2, 3, 4. In the fourth one, there are 10 features. You have to enumerate those 10 and differentiate the benign versus malignant. Got it? So based on the growth rate, benign tumors are slow growing, having low mitosis and high ducting time. The malignant tumors are fast growing, having high mitosis but low ducting time. And you can understand, I guess. Now coming on the clinical features, these are usually asymptomatic but exceptions are there. These are usually symptomatic but exceptions are there, and I told the exceptions also. Now coming on the gross, in the gross we have seen these are spherical in shape and capsule is present and they compress the surrounding tissue. These are irregular in shape, capsule is absent, they are not capsulated, and here they invade the surrounding tissue. Now coming on the microscopy, you have to enumerate the 10 features. What are the 10 features? The first is basal polarity. The first feature is the basal polarity, based on which differentiate the two. Second is the pleomorphism. Basal polarity, pleomorphism, ANSI ratio. The third one is the ANSI ratio. Then we have anisonucleosis. Then hyperchromatism or nucleus color. Hyperchromatism or chromatism of the nucleus. Then nucleoli. Then giant cell. Then mitosis. Okay, and then cytoplasm and aneuploidy. These are the 10 features. So here basal polarity is retained. Here basal polarity is must in anaplasia. Pleomorphism is absent here, but is a feature of anaplasia. ANSI ratio is low here. ANSI ratio is high in anaplasia malignancy. Anisonucleosis is absent here, but is present in malignancy. Chromatism, here the nucleus is normal color, and here nucleus is dark. That's why hyperchromatism. Here nuclei are not present. Mitosis is not present normally. You can see nuclei and mitosis is not present here. But here you can see the nuclei are prominent here. The nucleus is prominent here. Just a second. Okay, that page is gone. So we can revise that, okay, anyways. So that is based on these 10 features, we can differentiate the benign versus malignant. But in the end, we will revise it. Okay, these are the 10 features. I want you, rather learning the 10 features, draw them in a diagram. Try to draw all 10 features in one diagram. Try to show them in one diagram. Or you can draw multiple diagrams so you can show them. Now, for example, if a female is coming to us and female is complaining of irregular menstruation, we are doing a radiological imaging, and on sonography or imaging, we found there is a mass in the uterus. Okay, in the myometry of the uterus. You can see there is a one diagram, or you can draw multiple diagrams so you can show them. Now, for example, if a female is coming to us and female is complaining of irregular menstruation, we are doing a radiological imaging, and on sonography or imaging, we found there is a mass in the uterus. Okay, in the myometry of the uterus, you can see there is a mass or there is a mass. One of the two possibilities there. Okay, now based on that, what we can decide. So looking at the gross, here you can see this one is spherical in shape, it's well circumscribed, it is pushing the tissue, compressing the tissue, surrounding tissue. This one is irregular. Okay, and it is invading the surrounding tissue and no capsule is present. So based on the cross, this is benign, this is malignant. Now it's a gas, we cannot say it confirmatorily. So for that, we have to make a slide here, we have to make a slide. Do the biopsy or do the surgery and make a slide. Now this is a slide of benign, this is a slide of malignant. Whatever 10 features I told you, basal polarity, pleomorphism, ANSI ratio, anisonucleosis, mitosis, whatever, apply all 10. All 10 are absent here, all 10 are present here. So anaplasia is absent in benign and anaplasia is present in malignant. So based on which we will decide the treatment and further course for this. So any organ can have benign tumor and in the same organ can have malignant tumor also. But treatment will be different, prognosis will be different. That is the summary. Got it? So we have differentiated benign versus malignant tumor till now based on 4 features. Based on rate of growth, based on clinical feature, based on gross, and the microscopy is anaplasia. So based on microscopy or anaplasia also we have differentiated. Now finally the fifth and the last feature, the most important, spread of tumor. There are two types of spread of tumor. There are two types of spread of tumor, local spread and distant spread. Distant spread is known as metastasis. What do you mean by that? For example, this is the first one, and let's say this person is having any malignant tumor. For example, let's say this person is having a tumor of the stomach. Let me draw it. So for example, this is the GIT of this person. You can see this is the intestine. Okay, and these are the other organs I'm drawing here. Okay, multiple organs are just other organs. Now, just suppose this person is having a tumor or malignancy in the stomach. Okay, now this is a tumor. Now, this is a malignant tumor. What will happen? This is a malignant tumor. Now, so it will invade the same tissue, invade. In continuity, it will expand, and involve the adjacent organ. The adjacent organ can be spleen, pancreas, liver, it can be intestine. But the thing is that it's in continuity. It is in continuously. It is involving the adjacent organ. It is known as local invasion. This one is locally invading. Local invasion. Local invasion means tumor is invading the corresponding organs, multiple adjacent organs, but in continuity. Now after that, what will happen? After tumor cells will enter inside the blood, and from blood or lymphatic, it will spread to multiple organs, and it will form multiple secondaries and multiple other organs which are discontinuous from the primary. You can see the primary tumor is here, but multiple secondaries are formed which are discontinuous from the primary. The primary tumor is spreading via the blood or the lymphatic. So this multiple secondaries is known as metastasis. That is distant spread. Here the secondary tumors are discontinuous from the primary, but here in local invasion it is in continuity. I hope you got it. Now both these features, the local invasion and the distant invasion, that is metastasis, both of them are absent in benign and both of them are present in malignant. Mind my words very carefully. Both of them are absent in benign. Benign tumor neither show local invasion nor show metastasis. Malignant tumor show local invasion as well as metastasis. Please learn them by heart and carefully. Both of them are absent in benign. Benign tumor neither show local invasion nor show metastasis. Malignant tumor show local invasion as well as metastasis. Please learn them by heart and understand it. So I hope you are getting it. You can see this is the tumor. You can see the blue color is the normal tissue, and you can see the red color is the tumor. This is the red tumor is like a blue tissue. Okay. Now first it will locally invade, then it will go in the blood. Can you see this is the blood vessel? Some of the tumor cells are dropped in the blood, and via blood it is spreading. And going out. It is spreading via blood, spreading and going out. Extravasation in some other organ, where it is growing and showing multiple secondaries which are different. So both the features, the local invasion as well as metastasis. Benign tumor neither show local invasion nor show metastasis. Malignant tumor show local invasion as well as metastasis. Got it? Now there are 5 features based on which we will. Benign going out, extravasation in some other organ, where it is growing and showing the red tumor is like a blue tissue. Okay. Now first it will locally invade, then it will go to the blood. And see this is the blood vessel. Some of the tumor cells are dropped in the blood, and via blood it is spreading. And going out. It is spreading via blood, spreading and going out. Extravasation in some other organ, where it is growing and showing multiple secondaries which are different. So both the features, the local invasion as well as metastasis. Benign tumor neither show local invasion nor show metastasis. Malignant tumor show local invasion as well as metastasis. Got it? Now there are 5 features based on which we can differentiate the benign tumor from malignant tumor as I told you. Okay. Now this is the most reliable. We can differentiate them based on their rate of growth. We can differentiate them based on the clinical feature. We can differentiate them based on the growth, based on microscopy, that is anaplasia. The can features of anaplasia, and based on the spread. In the spread also there are 2 properties, the local invasion and metastasis. What is the most reliable feature? I told you in the spread, the 2 things, both of them are absent in benign and both of them are present in malignant. Local invasion as well as metastasis, both of them are absent in benign and both of them are present in malignant. I'm asking which is most reliable. So answer is most reliable is metastasis. If metastasis is present, it has to be malignant, there is no other choice. Rest all are, we are guessing. Now I'm saying you the benign tumor are slow growing and the malignant tumor are fast growing, but exceptions are. If I'm saying you clinical feature, benign tumors are asymptomatic, malignant are symptomatic, but again exceptions are there. Based on the gross, I'm telling you these are oval, spherical in shape and they have the capsule, they are irregular in shape, but again exceptions are there. Anaplasia is gray zone. Sometimes it is not always that you all the 10 features are absent here, all the 10 features are present here. Sometimes you get the gray zone. But if metastasis is present, it has to be malignant. So most reliable among all the most reliable feature is metastasis. The second most reliable is the direct local invasion. So most reliable and second most reliable feature, which is differentiating the benign and the malignant, is the spread of tumor. So metastasis is the most reliable feature which differentiates the benign versus malignant, and local invasion is the second most reliable feature which differentiates the benign versus malignant. And after that, the most reliable feature which differentiates the benign versus malignant, and local invasion is the second most reliable feature which differentiates the benign versus malignant. And after that, the third reliable is anaplasia. And here these are not reliable features, but based on which we can differentiate benign versus malignant. I hope the concept is crystal clear. Based on these 5 features, differentiate the benign versus malignant. Make this table. So you tell me benign tumor versus malignant tumor. See the clinical features and draws we have given together. The benign tumors are well encapsulated. The malignant are non-encapsulated. The benign tumor compress the surrounding tissue. The malignant tumor invade the surrounding tissue. The benign tumors are small in size. They grow slowly. The malignant tumor are fast growing. They are large in size. The secondary compress the surrounding tissue. The malignant tumor invade the surrounding tissue. The benign tumors are small in size. They grow slowly. The malignant tumor are fast growing. They are large in size. These secondary features are absent, they are usually present. All the 10 features of anaplasia, you know all the 10 features. You please enumerate: basal polarity, pleomorphism, MC issue, anastomosis, hyperchromatism, mitosis, giant cell, chromosomal abnormality. They all are absent in benign and they all are present in malignant. You can see they are absent in benign, present in malignant. Growth rate: benign tumors are slow growing, malignant are rapid growing. Local invasion and metastasis both are absent in benign and both are present in malignancy. Prognosis wise, benign tumor have less complications, so prognosis is good, but malignant tumor have more complications, so prognosis is good. So we have differentiated benign versus malignant tumor based on these 5 features. So please write down of your own the differences between benign versus malignant tumor here like this. So candidemicity based on the rate of growth, these are slow growing, having low mitotic rate and high loading time. These are fast growing, having high mitotic rate and low loading time. Coming on the clinical features, based on the clinical features, these are usually asymptomatic, exceptions are there. These are usually symptomatic, exceptions are there. Coming on the gross finding, grossly these are oval in shape, spherical in shape, and capsule is present. Here they are irregular in shape and capsule is not present. They
suppress the surrounding tissue, they invade the surrounding tissue. Now all these 10 features of anaplasia, they are absent in benign. All 10 are absent in benign. And all 10 are present in malignant. Please learn them by heart rather than learning to try to show them in diagram in your unit escape now. Well labeled beautiful diagram. And write down in your own words, all 10. You have to express in your own words. And finally the spread of the tumor. There are two types of spread. There are two types of spread of the tumors. Let me show you here the two types of the spread of the tumors. Both the spread of the tumors. Just a second. So both the spread of the tumors here you can see the local and the metastatic. They are absent in benign and they are present in malignant. Among all these features, the most reliable feature, let me tell you the most reliable feature. The most reliable feature is the metastatic. And second most reliable feature is the location. I tried my best to explain you the differences between benign versus malignant tumor. Please do check the long question, short question, very short question and answers on this topic in your notes section and question bank. And you get all these type of questions on this topic. It's a very important topic. Thanks so much. I hope you got it. Now everyone, in this session we are going to cover an important topic that is spread of tumor. So you usually